So good evening everyone. Welcome to the clinical case discussion ophthalmology. I hope you people are good, fine and enjoying this clinical case discussion series. Thank you so much for awesome feedback. I have got so many messages that you people are learning and you are getting the benefit in your what postings also, and this was missing from the last 2 years, so you are getting feedback and suggestion how to solve these clinical case scenarios. So I hope my audio video is clear. Can somebody tell me, give me a thumbs up if my audio video is clear? Anybody who can tell me? And once my audio video is clear, the first thing that you have to do today is that you have to tell me any clue about this. What is it? Hello everyone, good evening. So this is exam season. Many of the internal examinations are going on. We have got ward leavings and the entrance examination is also in the air. We have in the May. Hello. Thank you so much, Abdul. Hi, Manish, Shreya, Kanishk. Hello, everyone. Good evening. How are you guys? So, do you have any idea what is it? You can see something, a finding that is there over the cornea. A clue is there. Because actually when you read about the question you get a clue, then obviously it's becomes more easy for you. What questions? Mulay, I did not get your question, what you want to ask. Hypopion is not there. Shreya, what is a hypopion, dear? Hypopion is the pus in the anterior chamber. It's the pus in the anterior chamber. So that is totally different. We have got clear-cut demarcation whenever you have something in the anterior chamber. Like if you have hyphema, blood in the anterior chamber, then also you get a clear-cut level. But here you have got something else. Actually my purpose of showing you the pic directly is that so that you get to know that what are the things you can get confused in. When you read a question you get a hint and then you can tell me what it is, but when you see the image directly, how to actually move through it. Today's topics will be the clinical case discussion, which is starting with the image. Suppose you got this kind of a patient, so what are the things that you can think of? What are the things that will come into your mind? Can you tell me? So somebody said circumcorneal congestion. Shreya, yes, it was not a hypopion. There is circumcorneal congestion, right? But I am asking you the finding which is present over the cornea. What finding you are getting? So yes, it's a corneal opacity, but what is the name of this opacity? It's not a frank corneal opacity. When I talk about the corneal opacities, they are of three types. We have this one nebular, we have macular, we have got leukomatous. See, questions comes from question itself. So this is not a corneal opacity. Now I will give you some hint. Can you see, this is the opacity here. This is the opacity over the cornea. Now can you tell me what it is? You can see something which is present in a ring-shaped manner over the cornea, and yes, Shreya was correct. This is actually this is the circumcorneal congestion. So if you are getting circumcorneal congestion along with the opacity in the cornea, obviously then it's not a plain corneal opacity. So what you are thinking in the cornea then? Hello Ganesh. So Ganesh has given the answer. G for Ganesh and G for glaucoma. Yes, Ganesh. Ganesh, no, it's not glaucomatous corneal edema, but yes, circumcorneal congestion is there, which could be in the glaucoma itself. So don't worry if you are giving the wrong answer. I appreciate at least you are trying, and obviously one who tries only can make the mistake. So it's good that you are making the mistakes. At least you'll come to know what are the common mistakes you are going to do, what are the things that you can get confused in. So not a problem. Please give your pick, whatever you feel like, and obviously I am here to correct you and give the answer. So any other answer, guys? Acha, tell me. Okay, we can go other way around. Can you tell me what is the DD of this circumcorneal congestion? If I am getting the circumcorneal congestion along with the opacity of the cornea, what are the things I can think of actually? Can you tell me at least 3 to 4 causes? Tell me at least 4 causes. Okay, Sheikh is saying KF ring. KF ring will not have the circumcorneal congestion, you know. KF ring we have discussed also. KF ring you get in cases of the Wilson's disease, right? And this occurs due to the copper deposition. This is occurring due to copper deposition in the Wilson's disease. So you are not going to get the circumcorneal congestion. Moreover, it is golden brown in color. Okay, Shreya is saying fungal infection. So if you are saying fungal infection, Shreya, then what should be the name of this infection here? What should be the name of this sign or this presentation? What type of ulcer do we get in fungal, Shreya? If I talk about the fungal ulcer, okay, if I talk about the fungal corneal ulcer, then what are the typical things that we get? Last time I think we had discussed about the ulcers, right? Anterior uveitis, endothelial loss, Fuchs endothelial dystrophy. Okay, so if I talk about, first I'll complete the list for the circumcorneal congestion. One is acute anterior uveitis. This is correct. Balaji has given the right thing. It is anterior, also acute. It's a acute anterior uveitis where you can get the circumcorneal congestion. What are the other causes of circumcorneal congestion? Very good. Viral will not give you the circumcorneal congestion. Then you can have the acute congestive glaucoma. These are the 2 most important causes: acute anterior uveitis, acute congestive glaucoma, right? And then you can have the keratitis. Whenever we are having the acute keratitis, now in this acute keratitis, this can be bacterial keratitis. Then it can be fungal keratitis where signs are more than the symptoms. Then it can also be acanthamoeba. It can also be acanthamoeba keratitis, any of them. But mostly this is not the viral. If I talk about the viral keratitis, then you get the KPs and also the decreased corneal sensations. We get the KPs and the decreased corneal sensations in cases of viral. So it is not a typical feature of viral keratitis. Any other cause of the circumcorneal congestion? Yes, acute congestive glaucoma you people have said. Then you have said the anterior uveitis and you also have said the keratitis. What is the 4th important thing? The 4th important thing is the chemical burns. We can also have the chemical burns, like it can be by the acids or it can be by the alkalis. Whenever we have got the acid burns or the alkali burns, then that can also cause the circumcorneal congestion. Now your life will become easy. This is something out of these 4 things only. Can you tell me now? Something out of this only is the diagnosis which is given in the image. So now, is it uveitis, is it glaucoma, is it keratitis, or is it a chemical burn, right? You have to find out that. Now, if I talk about the fungal corneal ulcer, what are the typical features that you are going to get in the fungal corneal ulcer? First of all, it will be grayish. ulcer will be grayish, it will be dry looking, and you will have the raised margins, right? Then which is a thing which is very different from the image which is given here, you will have the finger like extensions. You will have the finger like extensions here. Why? Because we have got the hyphae, due to the presence of the hyphae, and then you also have the multiple satellite lesions. Multiple satellite lesions will also be there. Then what else you will have? You will have the immune ring of demarcation. Immune ring of the demarcation will be there, along with the big hypopyon. Along with the big hypopyon present. So you will have grayish, we have dry looking, raised margin, feathery margins. Signs are always more than the symptoms. Finger-like extensions would be there. Multiple satellite lesions. We have the immune ring of demarcation and a big hypopyon. So these are the features of the fungal corneal ulcer. Have you given the answer? Right? So what it is actually. Now coming back to this. So what it is actually a ring infiltrate. Can you see a ring like a feature? This is actually a ring infiltrate. Now moment I will give you the name of this lesion, that it's a ring infiltrate. Can you tell me now what it is? Because you know this word is very very typical of something. Where do you get Gokula? Tell me now. Yes, Gokul Krishna. Yes, Gokul Krishna will tell me that what it is. This is a ring infiltrate. Where do you get a ring infiltrate? Because again you can get this question that you have a ring infiltrate in the person, you have the circumcorneal congestion. So where do you get this ring infiltrate? This is a typical word where you get somewhere. Do you get in acute anterior uveitis, or you get in acute congestive glaucoma, or you get this in some kind of keratitis, or you get in chemical burns? So you have to tell me this, then we will start reading the question. Yes. Gokul Krishna will tell me the answer for this. Meanwhile, we will be reading this question now. So, we have a 32-year-old man. 32-year-old man is there who is complaining of right eye pain and discharge. Yes, Soumya has given the right answer. Very good, Soumya. So, we have a 32-year-old male who is having pain, who is having discharge, and symptoms begin acutely on awakening in the morning. He is also using the contact lenses. We have a history of usage of contact lenses, difficulty removing the lenses for the last week. Past medical history mein we have obesity, chronic backache, asthma and the acid reflux disease. Now on examination you have something thick globular discharge is present at the middle corner and the lid margins. Cornea is edematous, it's hazy, it's ulcerated. So see, they are saying that there is a corneal ulcer. They have given this directly that there is a corneal ulcer. So which corneal ulcer is related with the contact lens used? This is how you will pick up the words for your diagnosis. So they are telling that we have edema, we have haziness and we have ulcer. So corneal ulcer in a patient who is having the contact lenses. And also we have the extensive scleral injection. Scleral injection, here they are talking about the circumcorneal congestion. So what is the most likely diagnosis? Now see, all those things that we have discussed so far are already given in the question. We have angle closure glaucoma, there you can have circumcorneal congestion. We have anterior uveitis, there also you can have episcleritis. pneumococcal conjunctivitis and pseudomonas. Now you do not have acanthamoeba. Can you tell me the next best answer here? What is the next? Good evening, Robin. So if a person is having the corneal ulcer, okay, infection of the cornea, after the contact lens used, what is the first thing that you are going to think? What is the most common infection which is associated with the use of the contact lenses? The most common infection which is actually associated with the usage of the contact lenses is the pseudomonas. So acanthamoeba is also associated with the contact lens use, but if in order to make it acanthamoeba, you have certain important features. What are those features? What are the important features for acanthamoeba? If we have acanthamoeba, first of all, you should have the contact lens use, but after that, at least 3 important things. You will have pain which is out of proportion. Pain out of proportion to the size of the ulcer. Pain will be out of proportion to the size of the ulcer. Number 2, you will have the ring infiltrate. You will have the ring infiltrate or the ring abscess will be there. Ring infiltrate or the ring abscess. And number 3, you will have the radial keratoneuritis. Radial keratoneuritis. So these are the 3 important things that you are going to have in a patient of acanthamoeba keratitis apart from the use of contact lenses. Now, since in this case we do not have these things and we do not have acanthamoeba in the options, so you will go with the next one. Yes. So, tap water used for the contact lenses. So, anything which is actually related with the contact lenses, either they are using the tap water or homemade solutions, contaminated solutions, saline solutions, all these things. Sometimes, from the history of vegetative matter, trauma to with the vegetative matter, because, acanthamoeba is nothing but it's a free living amoeba which is present in the soil. So how this amoeba is actually going to the eyes with the help of this soil. So if there is a trauma with the soiled vegetative matter or there is a soiled water by which you are washing the contact lenses, by anything you can have this acanthamoeba keratitis. Can you tell me what is the culture medium for acanthamoeba? Culture media. These are the questions that are going to be asked from you in your ward livings also, in the Viva also. Suppose you get a case of acanthamoeba keratitis. Now, what are the common things? What are the other infections that can be related with the contact lens use? How you are going to find out what are the most important complaints of this patient? What are the confusing features of acanthamoeba with the other keratitis? And what is the diagnostic culture? What is the most important media on which you can do the culture for the acanthamoeba? Anybody who can answer this? The media? Hello, Sachin. Very good, Soumya. So, what is the most diagnostic culture media that actually you use for acanthamoeba? It is the non-nutrient agar. Non-nutrient agar we are using, which is enriched with the E. coli. Non-nutrient agar which is enriched with the E. coli. Very good, Sumandas. This is the culture media that we are going to use. Now there are certain confusing features. Number 1, number 2 and number 3. These are the 3 confusing features that I am going to tell you, which will help you a lot in making the clinical diagnosis of acanthamoeba, because many a times in the question of acanthamoeba you have these things and you get confused with bacterial keratitis, viral keratitis or the fungal keratitis. So if I talk about the fungal keratitis, fungal ulcers, What is the confusing feature with the fungal ulcer? You can get a history of trauma. You can get a history of trauma with the vegetative matter. You can get a history of trauma with the vegetative matter. Why? Because it is soiled. So through the soil it can come. So this is something which is confusing with the fungal keratitis. Number 2, confusion with the bacterial ulcer. If we have a confusion with the bacterial ulcer, you can look at the active stage of this acanthamoeba. The active stage is actually the trophozoites. It is the trophozoites. Trophozoites is the active stage which actually resemble the macrophages. And we know that macrophages will be present in the bacterial corneal ulcer. So sometimes you are seeing the trophozoites and you are confusing it with the macrophages. Then third is your viral ulcer. What is the thing that can confuse this one with the viral ulcers? Because you can have the pseudodendrites present. We have the pseudodendrites present. Pseudodendrites means something where you have the tree-like arborizing pattern. We have got the tree-like arborizing pattern that is present, where the normally knobs should be there and the floor should be there. If you see a true dendritic pattern where you have the dendritic ulcers, you have a floor and you have the knobs. So these knobs will be absent in cases of the pseudodendrites. So if it is something like this, then this is called as a pseudodendrite. Pseudodendrites are also found in the herpes zoster ophthalmicus. So these are the 3 confusing features. What are the confusing features? What is the diagnostic agar culture media that is there? Culture media which is diagnostic is your non-nutrient agar which is enriched with the E. coli. Now finally, once you have made the diagnosis, what is the treatment of choice? Anybody who can tell me what is the treatment of choice for this acanthamoeba keratitis? Treatment of choice is the polyhexamethylene biguanide along with the propamidine. Polyhexamethylene biguanide along with the propamidine is the treatment of choice. So I hope you have understood this acanthamoeba keratitis, all the important questions related to it. You have seen the important image also, the culture media as well as the treatment of choice. Any question related to this? Anything that you want to ask related to this? Okay, now your next image is this. What is this? You have got 2 questions. Number 1, the name of the test and what is the use of this test. There are 2 things you have to tell me. What is the name of the test and where do you use it actually? It's a common test and it's an important one also. So you have to tell me the name of this test. Alright. So anybody? Shreya? Ganesh? Soumya? Balaji? Yes. Okay. Anybody else? What is the use of this test? This is an important test. I have shown you this in the classroom also. This is what and why it is used actually. The name of this test and the use of this test. Okay. Yes, Soumya, it is polyhexamethylene biguanide, right? What is the name of this test? Yes, so I think everybody has given me the right answer. The name is actually the Amsler grid test. Amsler grid test is the name. What is the use of this test? Amsler grid test is actually used as a this is not a blind spot. Okay. Yes, Ganesh, it's a macular function test. It is a MFT, means it's a macular function test. It's a macular function test. The name of this test is the Amsler grit test, which is used for testing the macula. What is macula? It is something like this. So how many squares are there? We have got the 400 squares, which are 5 mm by 5 mm. 5 mm by 5 mm. It is the Amsler grit test, which is used as a macular function test. 400 squares are there, 5 mm by 5 mm. We have got the 400 squares, 5 mm by 5 mm. It is used as a macular function test. Anybody can tell me any other name of macular function test? Any other macular function test that you know? How to differentiate between the keratomalacia and corneal ulcer? Shabin, see, whenever they will give you a question, they will definitely give you something in the history also, na? If it is keratomalacia, then it will be due to the vitamin A deficiency. Then the patient will be a child. You will have other symptoms of malnutrition. You will have corneal cirrhosis also. You will have a conjunctival cirrhosis. Then you will have history of bitoid spots. Only then you will have keratomalacia. You will have history of change of epithelium from the non-keratinized to keratinization. In cases of corneal ulcers, it depends what type of corneal ulcer it is. If it is a bacterial corneal ulcer, then you will have history of discharge. If it's a fungal, then you will have history of trauma with the vegetative matter. If it's a viral one, then you will have history of either primary lesions. You will have history of herpes infection in any other part of the body also. You can have herpes labialis. Then if it is herpes zoster, you can have history of chicken pox. Then you will have typical lesions like dendritic keratitis, pseudodendritic keratitis. If it is herpes zoster, then you will have strict distribution on one side of the forehead. You will have Hutchinson's rule. You will have all the three divisions involved, frontal, lacrimal and nasociliary. If it is acanthamoeba, then we have already discussed. So obviously there are so many things. You don't have to just make a spot diagnosis, which will help you in making the diagnosis, right? I hope you have understood. Yes. Central cone rich part of the retina with maximum visual differentiation ability is called a macula. Yes, exactly, Ganesh. So the central part of the retina, which is densely packed with the cones which are responsible for the color vision, that part is actually called as a macula. So it's a macular function test. Okay, now based on this, let us try to read a question. Here you have got a 67-year male, okay, and this 67-year-old male is coming with the progressive visual loss in the right eye. So there is a gradual, progressive, painless diminution of vision. Can you remember this, DD? Who will tell me the most common cause of this? Gradual, painless and progressive. We have gradual, painless, progressive diminution of vision. We have got the history of hypertension. We have diabetes. Current medications include aspirin. We have hydrochlorothiazide, lisinopril, metformin. So he is a diabetic and hypertension, both are the risk factors, and he is taking anti-diabetics and antihypertensives. There is no family history of visual problems. So family history nahi hai, so a kind, you can rule out the glaucoma. We can actually rule out the glaucoma because usually, glaucoma runs in the families, and whenever you have gradual, painless, progressive diminution of vision, the two most important DD, one will be your cataract, right? And what will be the second important thing? Primary open angle glaucoma. These are the two most important things, and you have the history of hypertension also, diabetes also. So obviously you can think on the lines of the glaucoma, but they are saying no family history. Okay, then you have got History of smoking. Again, smoking will lead to cataract also. Smoking will lead to glaucoma also. And admits to occasional alcohol use also. Afebrile, blood pressure is on the higher side. Pulse is 73. Cardiac and pulmonary examinations are normal. Neurological examination also normal. Patient is asked to cover his left eye and look at a spot on a grid made up of parallel, horizontal and vertical lines. So, patient is asked to close one eye, and with the other eye he is looking at a grid. This grid consists of the vertical lines as well as horizontal lines. What is this grid? Can you tell me what is the name of this grid? He describes the vertical lines. Now see this. He is describing that the vertical lines are bent and wavy. So which of the following is the most likely cause of this patient's condition? So I think, this is a very, very direct question. If I give you directly the name of this test, what is this vertical grid? This vertical grid is actually your Amsler grid. Here they are talking about the Amsler grid test. So if you are getting the wavy lines and the bent lines on this Amsler grid, what is the diagnosis? Direct question which has been made as a clinical scenario. Right? Hi Satvik. Same to you Satvik. Happy Holi to all of you. Okay. Yes, very good. Inti Monica, Maddox rod test is also a macular function test. Very good. Color vision is also there. Even visual acuity is also there. Yeah. So it's a Amsler grid test, and if you are getting bent and wavy, then what is the meaning of this? Let me show you one thing here. See, this is your Amsler grid test that you have already seen. You have got the central fixation point, and there is a grid here of the vertical and horizontal lines. This is your 400 squares, which are 5 mm by 5 mm. These are your 400 squares, 5 mm by 5 mm. Now what they are saying is this one. Can you see? Bent and wavy. So whenever you get bent and wavy in cases of the configuration is bent and wavy in the Amsler grid test, then what is the meaning of this? This is actually a macular disease. Then it is a macular disease. Whenever you are getting bent and wavy pattern in cases of the Amsler grid, that means it's a macular disease. That means it's a macular disease. While if you get something like this, here you are getting the missing lines. Here you are getting the missing lines. So what is the meaning of this? Anybody? Bent and wavy structure is due to the macular diseases, macular pathology. Very good, Farhan. While if I get a missing line, something like this, if you are getting in cases of Amsler grid, then what is the meaning of this one? Anybody? Whenever you are getting missing lines, that means it is actually the optic nerve disease. That means it's a optic nerve disease. So what is a Amsler grid test? Where do you get a bent and wavy lines? Where you get a missing lines? These are the important questions which are related to the Amsler grid test. I hope you have understood. Yes, it is the optic nerve disease. It's a optic nerve disease whenever you get the missing lines. So this was your second case scenario. Now coming to the next one. Now can you tell me what is it, guys? I'll tell you exactly what you have to comment on. What are these? What are these? You can see something over the pupillary margin there. What are these? So missing line was your optic nerve disease. That's clear. Now what is this that you are getting on this pupillary margin? So you have to mention this. What is this? Anybody who can mention this? Very good. So yes, these are your iris nodules. What kind of iris nodules are these? These are the iris nodules. And which iris nodules are these? Exactly, they are present on the pupillary margin. So basically these are your coipae nodules. Therefore these are your coipae nodules. Where they are seen? Where do you get the coipae nodules? Coipae nodules you get in cases of the uveitis. Which kind of uveitis you are going to get this? So you are going to get this in the anterior uveitis. If I talk about the three kind of uveitis, this you are going to get in cases of anterior uveitis, and anterior uveitis also which type? Granulomatous. You are going to get in cases of the granulomatous uveitis. The coipae nodules are present in cases of the granulomatous uveitis. Now if you see here, let us read this question and let's see if we can solve this one. We have got a 5-year-old female, okay. So this female is coming with several months of history. I think it's 50, it's a mid-sprint. This female is coming with several months of the history of decreased visual acuity, decreased brightness sensation is also there. Slight exophthalmos of the right eye, that is also present, and ophthalmoscopy shows the pallor of the right optic disc. Then a very typical thing that you are going to get here is the cafe olate spots. Cafe olate spots are there. Axillary freckling is there. What is the most likely cause of this patient's condition? What is the most likely cause of this patient's condition? So first of all, can you tell me what is the diagnosis of this patient? That is very, very important. Very, very important. Shreya, you are answering for this question or previous image? I do not know. Chronic uveitis of sarcoidosis. Yes, it is found in the granulomatous uveitis. Coipae nodules as well as Busacca nodules, they are more common in cases of granulomatous uveitis, right? Now, if you look at this question, this person is having the pallor of the optic disc, brightness sensation is also decreased. So that means you have the patient having the involvement of optic nerve. So where do you get the optic nerve involvement? Along with the cafe olate spots, along with the axillary freckling. पहले ये बताओ, where do you get the cafe olate spots and axillary freckling? Then this question will become very, very easy. Very good. So obviously if I look at the cafe olate spots or if I look at the axillary freckling, this is a case of neurofibromatosis 1. Now what can be present in a patient of neurofibromatosis 1 due to which I can have the optic nerve involvement? Optic nerve involvement. In neurofibromatosis 1, we can have the optic nerve involvement in the form of the optic gliomas. How many percentage? What is the percentage of the people who can have the optic gliomas in cases of neurofibromatosis? Can you tell me the percentage? What is the percentage there? Exactly. I will show you the other nodules also. Don't worry, Shreya. I will show you the other nodules also. So obviously because it is related to, this question is related to nodules, that is why I showed you that also. First of all, can you tell me how many patients will get optic gliomas if they are having the neurofibromatosis? It is actually 15 to 20%. So 15 to 20% of the patients who are having the neurofibromatosis 1 can get this optic nerve gliomas. Now if you get the integration with the radio, what is the appearance on the radiological skin? What is the appearance that you get in cases of the optic nerve gliomas? Because you know you have got two things. One is your optic nerve, one is the optic nerve gliomas, and another is the optic nerve meningiomas. optic nerve gliomas is there, optic nerve meningiomas there, and we have got different appearance in the two types. 20% is exactly correct, 15 to 20% we have. So what is the appearance in cases of gliomas? You will get the fusiform enlargement. Fusiform enlargement you get in cases of the gliomas, while in cases of meningiomas we get the tram track appearance. We get the tram track appearance in cases of the meningiomas. Optic nerve gliomas and optic nerve meningiomas. In the gliomas you will have the fusiform enlargement, and in the meningiomas you will have the tram track appearance. You will get the tram track appearance. Again, very very important, because sometimes they will ask you directly the appearances also. This is your tram track appearance that you are going to get. Okay. Now what are the other things? So here the answer will be your optic glioma. Now what is the name of the nodules that you get in the neurofibromatosis? See this. Now here you have a mnemonic. You can easily learn this as your CAF spots. C-A-F-E, and then we have S-P-O-T. We have got the CAF spots. So cafe spots you get. So by that you can easily remember this CAF spot. So what are the things you are going to get here? So it is actually C for cafe or late spots that you are getting. This is your C. Then A is for the axillary freckling. See, this is a small effort so that you can remember. You know, you have so many things to remember. So these are the small tips and tricks by which you can easily remember. Then you have F. So the name is neurofibromas. So nerve involvement is there, fibromas are there. So you have got the fibromas that is there. Then E for eye. What you are going to get in eye? Eye may we get the Lish nodules. I will show the Lish nodules also. Shreya was also asking. Now can you tell me what are these Lish nodules? Anybody who can tell me what are these Lish nodules? Then we have got S. S may we have got the skeletal deformities can be there. Then we have got the P. P for positive family history. Positive family history can also be there. And O for the optic nerve gliomas. Optic nerve gliomas, that is there. So we have got the optic nerve gliomas, that is your tumors. This is the tumor. So you can easily remember. So what are Lish nodules? Lish nodules are actually the iris hematomas. Iris hematomas that are there, which we get in cases of eye. Now I will show you the appearance of these different nodules. So what are these Lish nodules actually? Lish nodules is exactly correct. These are actually the iris hematomas. Now can you tell me where do you get the brush field spots? Where do you get the brush field spots? Another important thing that you get, like one is the cafe spots. Cafe spots you get in cases of the neurofibromatosis. Lish nodules are there. Then you have the Koipe nodules and Busaka nodules that you get in cases of granulomatous uveitis. These brush field spots, where do you get? Yellowish dome shaped nodules over the iris. Yes, exactly. These are your iris hematomas. The hematomas which are present over the iris, these are actually called as the Lish nodules. The brush field spots you get in cases of the Down's syndrome. Down syndrome may you get the brush field spots. Now sometimes students message that how can we differentiate just from one picture the brush field spots? So maybe you are not. Okay, so whenever they are giving you the question on the brush field spots, definitely they will give you certain clinical features related to the Down syndrome also. So they will give you the Mongolian slant, they'll give you the trisomy and something else also. Only then they are going to ask you about the brush field spots. Obviously at your level, at your level you are not supposed to differentiate only from the brush field spots that this is actually the Down syndrome. Okay, Delin Lish nodules नहीं होता, it is the Delin Fuke nodules. Those are your Delin Fuke nodules. We have got the Delin Fuke nodules which are found in cases of the sympathetic ophthalmitis. Delin Fuke nodules are found in cases of sympathetic ophthalmitis. Yes, right. So if you see, this is again a pictorial diagram where you can get the different aspects of the neurofibromatosis. You have got the Lish nodules also. You have got the neurofibromas which are present under the skin all over the body. You can have axillary freckling, and you have this cafe olive spots also, brownet spots which are present. Now how to differentiate these? Let me show you that also. The different kind of nodules, so we can see at a time and you can differentiate it easily. See, these are the two kind of the nodules. These are your iris nodules which are found over the iris, which is found in the granulomatous uveitis. Now you have got two kind of nodules. The one is which are present over the pupillary margin. So one which are present just at the pupillary margin, they will be your Coipe nodules. And another are the ones which are present at the base of the iris or the mid periphery. So always remember that B for base and B for Busaka. So the ones which are present at the base of the iris or at the peripheral area, they will be your Busaka nodules. While Coipe nodules mein kya hai? We have got 2P. And if you look at the pupillary margin, then here also we have got 2P. Pupillary margin also 2P. So the ones which are present at the pupillary margin are your Coipe nodules, and the ones which are present at the base are your Busaka nodules. Then you have something which are your Lish nodules. See this. These are your Lish nodules. Can you see these brown colored ones which are present over the iris? These are called as the Lish nodules, which are the iris hematomas. These are the iris hematomas. The ones which are present over the iris are called as the iris hematomas. Iris hematomas which are present in your neurofibromatosis 1. And these are your brush field spots. Now can you see the difference? Shreya, I suppose you are seeing this. These are your iris hematomas, and these your grayish white in color. These are your grayish white in color, and plus these are at the mid periphery. These are present at the mid periphery. They are grayish white in color and they are present at the mid periphery, something like this. These are called as the brush field spots. Brush field spots are present at the mid periphery. ठीक है, these are present in the Down syndrome. And then a beautiful thing, see, this is amazing one. If you see, these are called as iris pearls. So जो brush field spots थे, they were present at the mid periphery, while these are actually the ones that I am showing you, these are just present at the base, a small pearl like appearance. So small pearl like appearance at the base is making a pearl necklace. They are making a pearl necklace, something like this. This is called as the iris pearl appearance. Where do you get this iris pearl appearance? We get this in cases of the leprosy. Iris pearl appearance is found in cases of the leprosy. So how many nodules you have done? Coipe nodules, Busaka nodules, Lish nodules, then you have done this one, brush field spots, iris pearls appearance, Delin Fuke nodules, and I hope you have understood all of them. Everybody has understood this. Shreya has also understood this, right? All right. Now coming to the next one. Okay, now see this case. This is actually a 48 years homeless man, and he is coming with the history of HIV, with floaters and the blurring of vision. So they are giving you a very clear-cut history. The patient is having HIV, we have floaters, blurring of vision. The symptoms started just a week, so it's acute one, and they're really bothersome. He has not had ocular pain. There is no history, right? There is no history of pain, fever, headache. The patient is taking actually the combination antiretroviral therapy that includes a protease inhibitor. Now 6 months ago, he was hospitalized with the pneumocystic pneumonia. Pneumocystis pneumonia, can you tell me where do you get most common infection? Pneumocystic pneumonia is most common in which one? Due to the medication non-compliance, disease got flourished and more of the disease led to this pneumocystis pneumonia. If you look at the temperature, it is 37.2, slightly raised, VP is normal, pulse is 78, BMI 17, vision is decreased, and you are getting yellowish white exudates immediately adjacent to the fovea and the retinal vessels, white patches on the oropharyngeal mucosa, no focal weakness or sensory loss. What is the most likely diagnosis? Yes. Now, anybody... Elshing's pearl. How Elshing pearls, Balaji? Ganesh is saying CMV retinitis. First of all, let us move line by line. Let us try to move. First of all, they are saying that the patient is having HIV. Right? So, if the patient is having HIV, this patient can have HIV leading to the retinopathy. Now, there is a difference between the HIV retinopathy and in a patient of HIV, we can also have the CMV retinitis. ठीक है ना? So, most common infection that can occur in the eye in a patient of HIV is your CMV retinitis. And then they are saying that due to the non-compliance, he was not taking the medication, the HIV got flourished. So, can you get pneumocystic? Yes. So, if there is a decrease in the CD4 count, if you are having the decrease in the CD4 count, then we can have pneumocystic lung infection. Now, when the CD4 count is decreased and the patient is having the lung infection, the patient can also have the CMV retinitis, which is occurring at CD4 count less than 50. When the CD4 count is less than 50, then I can have CMV retinitis also. Now, another important thing is that this patient is also having white patches on the oropharyngeal mucosa. Anybody, what is this? Why he is having white patches on the oropharyngeal mucosa? See, obviously, the main confusion is between A and D. Is it CMV retinitis or it's a HIV retinopathy? So, and what is this on the oropharyngeal mucosa? What it is? This is actually the candidiasis, which is again very common in the patients having the HIV. We can have the candidiasis. Now, if the CD4 count is less, I can have the CMV retinitis. But the thing is that in the CMV retinitis, what are the most common presentations? Either you can have the pizza pie appearance, or we can have the brush fire appearance, or I can have the brush fire appearance, and plus you will have the cotton wool spots. Now here we are not having any such kind of presentation, the pizza pie appearance or the brush fire or the cotton wool spots. What is your diagnosis? Can you give me? Yes, exactly. Now I am getting the comments. Pizza pie appearance, है ना? Oropharyngeal mucosa पे you are having candidiasis and less than 50 CD4 count पे we have this one. Now, because I am not having any such thing, therefore, the answer to this question is HIV retinopathy. So, basically, it's HIV retinopathy which has occurred and it has become too much. And that is the reason why this patient also has led to the pneumocystic pneumonia, and we are having the cases of the candidiasis also. We are having the white exudates and floaters are there, blurring of vision is there. That is why answer to this question is HIV retinopathy. So, answer is D. If I have this what you called as a CMV retinitis, then I should have the cotton wool spots, I should have the CD4 count less than 50, brush fire appearance, pizza pie appearance, and these things will be more common, which you are not getting. Therefore, the answer to this question is HIV retinopathy, right? Okay. Now, there is one more question which you have to actually give the answer. The yellowish spots which they are saying, Ganesh, is actually the exudation. If they will say about the cotton wool spots, then they will say it is the whitish one. Okay. So this is one question that you will have to answer, guys. We have got a 26-year-old man who is coming to the physician with the sudden onset of redness, watery discharge. We have got itching. The vision is slightly distorted from the excess of tearing. So we have got a lot of watering here, and we have sudden onset of the redness. We have serious discharge, watery discharge. What are the things that you have to take into consideration due to watery discharge? Where do you get watery discharge? This is your first thing. Then you also have itching. This is the first question. What is the DD of watery discharge? Your second question is, where do you get the itching? Then excess of watering is there, otherwise he is fine. The patient's medical history, past medical history is significant for obesity, asthma, sleep apnea, as well as chronic backache. On examination, we have got bilateral injection with granular appearance of the conjunctiva. We have got the granular appearance of bilateral conjunctiva. Then eyelid swelling is there, clear discharge is there, pupil equally round, pupils are reactive to light. We have got wheezes. So your third question is what is wheezes? Wheezes suggestive of? He has a faint systolic murmur. What is the most likely diagnosis of this patient? So there are three questions that you have to answer actually. No, I don't want the direct answer. I first want you to go through the proper channels. First of all, you have to give me the DD of the watery discharge. If you are having a watery discharge in a patient, then what are the things you have to think of? I am not saying that answer is right or wrong, but I am saying what is the DD if I am having a watery discharge. What are the things that you have to think for itching, and what is the thing that you have to think in cases of wheezes? Wheezes में क्या होगा? So I am getting A and C, but I am not getting C. If I am getting the watery discharge, then what are the things you have to take into consideration? Very good. So if I am having watery discharge, either it can be a viral conjunctivitis or mostly it can be allergic. In both the cases, I can have the watery discharge. Viral may be, allergic may be. Now if I have itching, then it is going more in the favor of allergic conjunctivitis because I am having itching. And the third question is wheezing. Wheezing is also going in the favor of allergy. So basically we have got allergy, and allergy. Therefore, yes, answer is allergic conjunctivitis. So answer is allergic conjunctivitis. So can you tell me, if it is a allergic conjunctivitis, what is this bilateral injection with the granular appearance with allergic conjunctivitis is most common? Number 4 question है, which allergic conjunctivitis? Which is allergic conjunctivitis is actually most common. Which allergic conjunctivitis is most common? Anybody? Wheezes allergic. Exactly. So which allergic conjunctivitis is most common? Yes, it is the vernal keratoconjunctivitis, VKC. So what is this bilateral injection with the granular appearance? So this is actually your cobblestone papillae. This is actually the cobblestone papillae that we are getting in cases of the bilateral conjunctival. So this is the cobblestone papillae. We have got Horner Trenta spots. We have got intense itching. We have got the Maxwell-Leon sign due to the pseudomembrane formation. And now one important thing. What is the treatment of choice? Exactly. It is a vernal. Victor nahi hai Arshad. Vernal. Very good. Vernal keratoconjunctivitis. What is the treatment of choice? इसको हम treatment of choice पे sum up करेंगे. What is the treatment of choice? history of the chronic back pain, can it be associated with anterior uveitis? Definitely. If you have chronic lower back pain, you can have anterior uveitis, but in anterior uveitis you will not have itching. There is no place of itching here. Then you will not have the granular appearance. You will not have equally round. You will have meiosis. In the uveitis, you will have meiosis, you will have fixed pupil, you will have KP, circumcorneal congestion, right? So that are the things that you are not going to have, right? Okay. तो ट्रीटमेंट ऑफ चॉइस क्या है? ट्रीटमेंट ऑफ चॉइस ऑफ वर्नल केरेटो कंजंक्टिवाइटिस, कैंथमीबा नहीं. Very good. Exactly. Treatment of choice is olopatadine. It is the olopatadine. Treatment of choice for the vernal keratoconjunctivitis is the olopatadine. So, exactly. So, that's how we have come up to the end of the session today. Today you have read about acanthamoeba keratitis and the pseudomonas, that is the keratitis related with the usage of the contact lenses, very very important. Number 2, we have read about Amsler grid test, macular function test that you have read, okay. Then we have read about the different kind of nodules, Lisch nodules, you have read about Kuiper nodules, Busaka nodules, brush field spots, all these things, a case of neurofibromatosis, optic nerve gliomas, you have read about a new mnemonic also, Café spot, and then finally we have read about this allergic conjunctivitis. So I hope with me, as much as I am enjoying, you are also enjoying doing these clinical case scenarios and learning also and testing yourself how to approach these questions, and you will see that you will start enjoying it more. More we practice, more we enjoy it, because you start learning the art of diagnosing. That is a fantastic feeling. Just from few lines or just from few signs of the patient, you are able to diagnose the thing, and then your life becomes easy. You can easily tell how to diagnose it, what is the first test, what is the best test, what is the next step, or what is the treatment of choice. So keep reading, keep enjoying. See you next week, same time, same day, in the clinical case discussion. Happy ophthalmology. Thank you and bye-bye.